Hello, and welcome to the Nursing Economics podcast series. This series provides extended content relating to articles published in the journal, such as author interviews and roundtable discussions. This episode accompanies the article Lessons Learned from Nurse Practitioner Independent Practice, a conversation with a nurse practitioner entrepreneur published in the January-February 2018 issue of Nursing Economics. This article was co-authored by Dr. Joyce Hahn, an associate professor at the George Washington University School of Nursing in Washington, D.C., and Mr. Wesley Cook, a nurse practitioner entrepreneur, also in Washington, D.C. It provides an overview of advances in nursing regulations alongside strained access to primary care for an aging population, prompting an entrepreneurial opportunity for nurse practitioners, especially nurse practitioners in states with full practice authority. Full practice authority affords the nurse practitioner, as an advanced practice registered nurse, lawful control of and full liability for evaluation and management of patients in his or her charge. It eliminates financial barriers to entrepreneurship unique to advanced practice registered nurses and allows for fair market competition. Full practice authority also serves to advance the profession by allowing creative pursuits outside the framework of medicine. The article provides an overview of lessons learned in establishing and maintaining a sustainable business model within the context of full practice authority. We are pleased to present Dr. Joyce Hahn's interview with her co-author and colleague, Mr. Wesley Cook, for a deeper dive into entrepreneurial drive, development, policy participation, and planning in this episode.
This is Nursing Economics, and I'm Joyce Hahn, Associate Professor of Nursing at the George Washington University School of Nursing. I'm here today to interview NP entrepreneur Wesley Cook, the President of District Primary Care in Washington, D.C. This podcast is a supplement to our article, Lessons Learned from Nurse Practitioner Independent Practice, a conversation with the Nurse Practitioner Entrepreneur, published in January's Nursing Economics. Thank you for joining me, Wesley.
Thank you for having me, Joyce. It's quite the honor.
Wesley, speak to me about why you feel so strongly about reimbursement for NP business models.
Reimbursement is really a way for me to embody the business values that I have. One of the things that really frustrated me about being a registered nurse was being an indirect part of the profit generation. You know, as a registered nurse, you're part of the bed costs in the hospital, and one of the things that I really liked about being a nurse practitioner was that I was generating the cash. And so direct reimbursement as a business owner allows me to go straight to the payers themselves and be reimbursed as the physicians are. It's an empowering position for APRNs to be in, and that's another issue of business value that I really take seriously as a business owner. It's a way to advance APRN practice. I wanted to be my own boss, number one. I wanted to be able to precept students without having to go through a ton of red tape in order to do that. I wanted to work the amount of hours I wanted to work in a day and be reimbursed accordingly. If I saw a whole bunch of patients in 12 hours, I didn't want to be pigeonholed into 8 hours of pay. The flip side of the freedom from salary is that you don't have the security of salary, of course, and I have had lean months, is what we'll probably call them, but overall, I wanted the satisfaction of doing my job without being hamstrung by answering to someone else. And as I think about my position as a nurse practitioner, it's really important that I maintain a sense of being a professional. And since part of the definition of a professional is being paid for the services rendered, I feel like if I'm going to represent the profession well as a person who has business acumen, then going straight to the payers, being at the table in the insurance world is really important as an APRN.
All right. So your answer leads me to my next question. How have the business values that you've just spoken about, how has that shaped what's next for your practice?
Well, if you had asked me this 3 months ago, I think I would have answered differently. But as we record this, Congress is currently deciding whether or not to drastically reshape health policy in the United States. And as a nurse, I find it alarming. As an American, I find it alarming what we are getting ready to do. But as an APRN, I find it downright unsettling, to be perfectly honest. the physician fee schedule has been contingent on a system wherein every year Congress decided whether or not they were going to decrease the amount of reimbursement, and then that ricocheted through all of the different payers. We got rid of that with MIPS, the new payment system. And now that we are looking at dismantling Obamacare, or the American Affordable Care Act, rather, and all of the rhetoric that's currently going into that, business planning has been a little bit difficult for 2018 and beyond, especially as I look at being a person who takes pride in taking public payments. I believe in a public payment model. I think that it is my responsibility as a care provider to make sure that I'm rendering care to people regardless of their ability to pay. Now, I have to keep the lights on. So payment's important, right? I value my services, and I think that they are worth money. And so there's that component of it. However, I am happy to take less of a reimbursement from somebody who uses a public payer than someone who has Cadillac insurance, like a Platinum Care First plan that reimburses way top dollar compared to something that Medicaid would reimburse. But all of that said, the business values of teaching, having a place to teach, having a place to exercise my own values, having a place to exercise what I have learned in my Doctor of Nursing Practice program about quality management and about leading with a quality eye. Those things are being shaped by reimbursement models that are value-based now. We're moving less and less away from fee-for-service and more toward a value-based system. And so I use this opportunity that the district gives me to have independent practice and try and shape my business in a way that allows me to care for the person who is on a public payer system in a way in which I'm not punished for only taking care of that patient because it's so volatile at the moment. So I pad all of that with aesthetics income. My secondary board certification is in plastic surgical nursing. And so as I look for what is next in all of this, I think that I'm probably going to be expanding the more cash-based part of the business in order to really serve what I feel are patients who need service regardless of what the current political climate is going to allow them to have, especially as CHIP is up in the air.
I see. So you work within your niche market to remain solvent in order to provide care to those geriatric patients.
Very much so. And as we are at the tail end of the year and I'm doing all of those things that business owners do, like look at my balance sheet and make sure that my profit and loss report is considered as I do my budget for 2018 and beyond, it's become really clear that the profit center for this is not the care that I love doing aesthetics. It's not that I don't love doing it. It's instantaneously gratifying. You see it happen. It's fun. It's a kind of nursing that I never thought I would get into. I fell into it by accident. But the mental challenge of diagnosis and management of illness really, really speaks to me. And being able to teach budding APRNs how to manage their own mind in order to wrap their head around presentations that are typical and atypical, that may look like something they're actually not. You don't get that satisfaction in aesthetics. But it's a business, and the money is very good in aesthetics. So I keep both in order to really serve a market that I feel strongly about serving.
You weave policy into your business model. Can you speak specifically to how you see your practice affecting policy?
I really wish I knew more about policy. Some of the classes that I've loved in my master's and doctoral education have been the policy classes. I didn't expect to like them. And as I think we are all finding, inside and outside of the healthcare arena, this is a very complicated problem that we have. On a micro policy level, the policies I most see the ability to influence are the barriers we still have as APRNs to practice in a full practice authority setting. I operate in a full practice authority jurisdiction, but I still have federal limitations. The CMS regs, or the Center for Medicaid and Medicare Services regs, that still keep us hemmed up are in some pretty key areas of care that are nursing-centered. Nursing homes, hospice, home care. As an APRN, I can operate in all of those settings, diagnose, manage, prescribe, do all the things that my APRN license gives me the privilege to do, except certify a person as terminal in a hospice setting, certify their condition as terminal, rather. I can't order home health services. I can't admit someone to a skilled nursing facility. I could admit them as a long-term care patient, but I can't admit them as a person who needs a skilled level of care. And I see, as I work in the skilled nursing facility world as a contractor, with a physician who we have our own panel. I take my job very seriously. I don't do the scut work as a lot of physicians want to use NPs in that world. I'm not there to sign papers and write prescriptions. I'm there to see patients. I'm there to manage their total wellness. And so because I need a physician partner in that, I do have a physician partner who works with me in that arena. The more I've worked in that arena, the more I've realized that this is the area where thorough business models that are NP-centered, that are really taking the team approach seriously, where the NP works with the LPNs, because a lot of these places are LPN-centric, not RN-centric. And they're not trained in assessment. They're not trained to do anything but data collect and report, right? And that's helpful if what you want is a collection of data, but that's not helpful if what you're looking for is someone to pick up the phone and give you an assessment of the situation. So I think that an advanced nursing level in these arenas would be very helpful from a systems issue and beyond. So I see business models that allow the NP to practice in a much more expanded scope in that way, to give leeway to studies that then give data to the argument that we are actually really good at this, and we need to believe in ourselves a little bit more. The data on NPs in primary care, especially Mundinger's data, is very compelling. It's been replicated. It's really great. We've got a lot of good information on the outpatient setting. We don't have any barriers to knock down in the outpatient setting on a national level. We need to start knocking down the barriers we've got. People need access to hospice. They need access to skilled facilities. We need to close the loop on the days that they spend in a skilled facility. I can't admit someone and discharge them and take them through the full continuum of care because I'm handcuffed because I have the wrong credentials as far as they're concerned. So that's one huge way I see myself as being able to affect policy with my business.
Thank you. For NPs who don't own their own business, how does all of this information and insight, how does that transcend into being an employed practitioner?
Well, I think I get this question a lot, actually, from friends who are, or colleagues who are employed NPs, and they like being employed NPs, because let's be honest, the headaches of business ownership are myriad. I find that the rewards of business ownership trump that, and so I'm okay with those headaches. Being a salaried employee has headaches too. One thing that I find that many salaried NPs don't take seriously enough is their ability to negotiate their contract. See yourself as a brand. You are a brand. You may be part of a larger brand, but what kind of care are you giving? When a patient comes to see you, how are you different than everyone else in your practice? How are you different than every other NP or physician that works in your area of competition? If we thought about this much more as a personal brand as employees, I think that we would think a lot more about a contract that's laid in front of us for $75,000 for an entire year's worth of work at 2,080 hours. I think that's full-time, right? It's been a while since I've calculated all of that. And I think that's not a skill that we're taught from first principles as nurses, negotiation. We're taught assessment, we're taught reporting, we're taught to argue the case, We're taught to argue down the case, especially if we worked in really highly acute areas. But negotiation, sitting across the table with numbers that personally affect you, that's not a thing that we're taught very explicitly as nurses. And because of the altruistic undertones of nursing, I think there's a lot of people who feel badly about asking for more money. And I think that's ultimately detrimental to the entire profession. Anyone who's taking less of a salary because they don't feel comfortable negotiating is actually undercutting the salary potential for the entire country. So when we look at these things, I don't sit down to do a contract negotiation until I know what my competitors are being paid.
Interesting.
And so when I sat down originally to talk about salaries when I thought that I was going to be a salaried NP, I wanted to know what the physician with similar experience made. And I wanted 85% of that salary. And if I was not going to see the same number of patients in the day that that physician was expected to see, then I was fine with that being prorated. But if I was seeing the exact same amount of patients as a physician with the exact same amount of experience, and that physician was making let's just say $200,000 to make that a clean number, I expected $160,000 salary plus benefits because I'm making 85% of the salary. Based on the reimbursement principles. We usually make 85% of what the physician fee schedule is. If I'm only going to be seen as a way to generate more profit for the practice because I'm going to do the same kind of work but be paid much less, that's not a kind of business that I'm interested in. And so I've always approached this as a business owner. What's my balance sheet? Even when I was thinking about being a salaried employee. From a business owner to a salaried NP, that's my biggest piece of advice. What is your brand? How much is your brand worth? Do you know how many patients you can see in a day? Compare that with somebody of credentials that is being paid 100% of the fee schedule, and then start your negotiations from there. I think we really lose out by not believing in ourselves in that way.
Good words of wisdom there. So Wesley, thank you for sharing your insights, your experiences, and certainly your vision for NP business models. To our listeners, if you want to learn more about developing business models as an NP entrepreneur, then I urge you to look for our article in this month's Nursing Economics.
The Nursing Economics podcast series is owned and produced by Genetti Publications Incorporated. All rights reserved. No portion of this podcast may be used without written permission. Mr. Wesley Cook is a nurse practitioner entrepreneur in Washington, D.C., and owner and president of District Primary Care, LLC. Dr. Joyce Hahn is an associate professor at the George Washington University School of Nursing in Washington, D.C. For archived episodes of this podcast and to learn more about nursing economics, visit the journal's website at nursingeconomics.net. You can also subscribe to the Nursing Economics podcast on iTunes, Google Play Music, Stitcher, TuneIn Radio, our hosting site Spreaker, and other various podcast delivery services.